So let's start. This is the first one. Very easy questions, and these are the diagnoses that you should not miss at any cost. That is why they have been put. Few spotters are repeat in different modality and different gestation. More or less, this is early pregnancy scan. So yes. What are these? The hyperechoic structures. What are these? So these are the bones. And do we see any bony structure in the region of head? No, we don't see that. So if at this gestation we don't see bones in the calvaria, the diagnosis is great, acrania. So the cranial vault is absent and the brain matter is exposed to the amniotic fluid. And these hyperechoic structures, basically these are the facial bones and they are preserved. So the first step is acrania, then the brain matter goes out and is floating. Eventually it undergoes liquefactive necrosis. It gets dissolved in the amniotic fluid. So Acrania-exencephaly, and then completely absent in encephaly. Very good. So Acrania-exencephaly sequence. Okay. Already labels are there. So first question is, what are the findings? And the second question is, you have to tell me the associated syndrome. You can answer anyone, A, B, anything. And what syndrome do you specifically associate? Basically, the pattern recognition system works in such a manner that when you're doing a scan and you got one finding, now the next step is your brain should work that this finding is associated with so-and-so syndromes and start looking for the other soft markers. The moment you get 2 or 3 soft markers, then you know that this syndrome can be, this baby can be syndromic baby, and then further workup and genetic counseling would go. So that's how the diagnosis will follow. Okay, so I'll help you. So first, these structures are orbits. Okay, we are doing very early scans. So say this is an NT&B scan. So these are the orbits. And this is a PMT view. So we see a cystic structure in the brain adjacent to occiput. So some posterior fossa cystic structure. And this is the PMT view. So ideally, we should have complete triangle. And these arrows are pointing to defects in the inferior triangle, the inferior part of the triangle. So what does that inferior part forms? So you have defects there. So what structure is affected here? Okay. So this is the future. Palate. The maxillary process will join to form the floor of palate. So defect is there. And for encephalocele, skin should be defective. The occiput should have defect. That is intact. This is a cystic structure intracranial. So the first thing is this is a 12-weeker. We are seeing a posterior fossa cyst. So if a cyst so large that it is coming up in the first trimester scan only, it's likely consistent with Dandy Walker malformation. And then you have bilateral cleft palate and the lips. Okay. So any syndrome associated? Which comes first to your mind that I should look for the findings? Very good. Okay. So trisomy 13, the common ones first. So when you see these 2 findings, start looking for other patterns. So this year NEET SS question, I got some queries on the social media and they told me that questions were of this sort, where they said absent nasal bone and thickened NT is associated with which of the following syndromes in the order of, how common it is. So this type of questions can come in NEET SS. If you're preparing, you should know. Okay, easy one, but very typical, very classical. Everything is labeled. Okay, I'll explain cleft palate again. But this one, very good. So this is the heart and this is the body of the baby. And when we are doing scan, we see the heart is located outside the body. So there is herniation of the ventricles and the atria. So if the heart, that is both the ventricles and at least one atrium is herniating, this is ectopia cordis. Excellent. See, a triangle, when you, we have a PMT view, pre-maxillary triangle view. So both the maxillary process, the nasal bones and the palate, the future palate forms that triangle. So anywhere defect, if the apex of triangle is not formed, it is likely a case of absent nasal bone. If the palate is not complete, it's cleft palate. Now, if we go anteriorly, if I'm going anteriorly, I'll see lips. So if I'm seeing a complete mandible, I'm likely anterior to the PMT view, and that's why the nasal bone is not seen very nicely in this view. So this is also suggesting cleft lip. So now lips are such a structure which is going to appear later. Like in 20 weeks, you see very nice and beautiful lips. But at this point of time, you have soft tissue. Like the lower lip looks fine, but here you are having two defects. And even the bone is not visualized. So it's likely a complex. So when the triangle is not complete, be it apex or the base, it points to a diagnosis. If apex is not seen, absent nasal bone. If the palate is not intact, it's cleft palate. Okay, so this was ectopia cordis. Next, easy question again. So do you want to know something about this baby? If you want, we can you can ask a question. Do you want to know, is it twin or singleton pregnancy or gestation? Are you interested in knowing the gestation of this baby? Yes. So the gestation is 10 weeks. We see some soft tissue at the base of umbilical cord. How do I know this is some soft tissue and it is not a part of the umbilical vein and arteries? Because we don't have any color flow. The box is big. No color flow here. So, okay, now we have two answers for this. Somebody is saying it is physiological hernia. I suppose you want to say that. And one is saying that it is gastroschisis. Okay, we do have an option of omphalocele also. Now you tell me, how do I differentiate an omphalocele / gastroschisis, something which is pathological, versus a physiological herniation? By the period of gestation, excellent. So 10 weeks, I'm seeing a 4 mm small soft tissue area at the base of umbilical cord. So this is physiological gut herniation. This should ideally resolve by 12 weeks. If it doesn't, and if you see it persistent in the NTNB scan, then it is pathological. Now, this is an NTNB scan. So this is the fetus. We see a defect here, and the intra-abdominal contents and organs is going outside, but they are within a well-defined sac because the sac is helping in maintaining the contents in a shaped thing. So there is a membrane around it. This is the corpus. How do I know that? I see the spine. Okay, so this is 12 weeks baby, and because of the well-maintained shape and herniation at 12 weeks, I know it is not physiological anymore. This is omphalocele. Omphalocele is associated with trisomy 18. Okay. So the first image is telling me that we are attempting to do an NTNB scan. So now there are two findings in this. Very good. We have something irregular bulging and the umbilical cord insertion is normal. Do you see any other finding in this? So this is the irregular structures, the small bowel herniating. Very good. So we see the NT is also increased, right? So two things. free floating bowel loops without a sac, and you see the thickened NT here. Yes, this is gastroschisis. So physiological herniation, omphalocele, and gastroschisis. Physiological herniation, gestation will tell you this is physiological. Even the location, base of umbilical cord, small structure. Before at 8 to 10 weeks, you will get that. After that, if you're seeing something which is bulging irregularly, floating, free floating loops, and lateral to the umbilical cord, which shows normal insertion, gastroschisis. And if you're having a herniation within a well-defined sac, it's omphalocele, but period of gestation should be known for diagnosing these. Okay. Now, this is a baby at 14 weeks. So we did a scan at 14 weeks, and we see a structure within the label here, followed by 4 weeks follow-up. And now the structure has increased in size. So first, what are we focusing at? We are focusing at kidney. Very good. Excellent. So first, this was a kidney which is enlarged, and you have multiple non-communicating cysts. As the gestation increased, the size of the kidney and number of cysts have increased. So diagnosis is multicystic dysplastic kidneys. ADP kidney, not very significant, will be diagnosed postnatally. ARP kidney, usually bilateral involvement. Liker is usually very low and poor prognosis. So this is the classical picture for multicystic dysplastic kidney. Very classical spotter. Again, I was doing NT&B scan. We see the nasal bone nicely equal to sign. But what is this? This is something which is bothering me. Otherwise, the scan was done almost. Yes. We did scan 2-3 times, but still this thing is persistent. So this is a fetal bladder, measured craniocaudally 13 mm, megacystis. Right? Oh, so sorry. Uh-oh, it's already working. This is 14-week gestation. We see clubfoot and multiple toes, 1, 2, 3, 4, 5, 6. Okay. How are we diagnosing this to be clubfoot? How do you diagnose clubfoot? When you are able to see the sole of foot, yes, and the leg bones in one plane. So that tells me the same plane that it is medially deviated, and we can see the sole as well as the leg, right? So I think it's easy to pick. Very classical spotter, although rare. 2 findings. Excellent. Conjoined twins. So this is again an NT&B scan. What is this? Diffuse subcutaneous edema, septated cystic hygroma. Very good. So NT is thickened. Interesting case. Beta HCG is way above the roof. Okay. Excellent. But beta HCG is increased. I've given you the hint. First question. It can be partial mole because I see first the cystic grape-like vesicles, everything partial mole. And I see the baby also, some part of the baby. So partial mole. But what if I tell you this baby is hale and hearty, bilkul fine baby, good cardiac activity, moving, ND present, everything is good. Then now does your diagnosis change? Beta HCG is still very high. So what is the condition where you have the fetus is absolutely normal and I don't see amorphous baby and this snowstorm appearance? Diagnosis? Excellent. So this is a twin pregnancy. So live normal fetus with a heterogeneous cystic placental mass showing me snowstorm appearance. So this is a twin pregnancy. One with H mole, other is normal. Okay. Had it been an amorphous mass of tissue of the fetus, this would become H mole. Okay, so this is twin pregnancy, complete H mole, and a coexistent normal fetus. Now, this is one case where I see few cases where there is an echogenic structure attached to the chorionic tissue, and it confuses me a lot. So what is this? This part of fetus did not have any heart. Very good. This is chorionic bump. Excellent. So this focal echogenic mass, which is bulging into the amniotic cavity, is a chorionic bump, and this is an amorphous fetus which did not have cardiac activity. So diagnosis is non-viable intrauterine pregnancy. Okay. Now another interesting question. So it's a mixed bag, easy and little dicey cases. So NT-NB scan again. CRL is 60 mm. I see some NB, but this is not the view. We can do better. This is a section where I was trying to take abdominal circumference. One structure is missing in this. If you name that structure, you will get, it will strike you. The diagnosis will strike you. No, NT is fine. See, there's no subcutaneous edema. These are the ribs. One side we see complete rib, other we are seeing dots, so not a proper section. But we are missing stomach. Excellent. Now I'm not able to see the stomach. Yes. So this is an NT scan. I'm not able to see stomach. 30 minutes later, again check. Stomach is not seen. Not visualized. So differential. What does your brain think of? Can this be an abnormality? It can point to an abnormality. Excellent. So I was having, the baby was in sagittal position, so turned on the color. Turned on the color. This is the baby, and this image on the other side is for your reference. Now, this image is telling me the answer. I want you to tell me which sign is this. We are not discussing the angle. Yes, we are focusing on a structure. This is my superior mesenteric artery. Can you look at the direction? Very good, Dr. Raj, amazing. Yes, so this is upturned SMA sign. Normally it should go and supply the bowel. This is the normal picture. But if it is going cranially, that means something has gone cranially. It is following it. The vessels are following that structure. And this is the diagram for you. Went to the thorax, took my probe, slid upwards. I see heart. So this is 2D and this is the color image. First of all, heart does not look to be towards, maintaining the normal axis and the position. I see a cystic structure in thorax. So is my diagnosis clear now? Stomach is visualized in the fetal thorax. This is CDH. Yes. Okay. So these things, a large CDH can be easily picked up in first trimester scan. And the first sign is you don't see the structure where they should be. If stomach is not present in the AC section, so first it can be collapsed. Call her after 10 minutes, 30 minutes. Still not seen, then you look for the other structures. In the same sweep also you can look. Okay, easiest. Pretty easy. CPAM, good. Okay. First, what is the finding? And if this finding comes, what is the next structure that you will be looking at? Good. So this is urinary bladder. I'm not able to see the other umbilical artery. So this is single umbilical artery. What structure should I now look for? So single umbilical artery is associated with which organs pathology? Most commonly seen in diabetic mothers. Now start looking for KUB structures, kidneys. Okay, so very good. Now we see a finding here. Okay, the finding is increased NT. Start telling me what are the associated abnormalities. Very good. So first, most commonly we have seen that chromosomal abnormalities manifest in the form of increased nuchal translucency. So first is trisomy 21, 18, 13, so all the three trisomies. Turner, very high NT. Triploides, then the sex chromosome aneuploides. Then there are some structural anomalies, the non-chromosomal ones, the ones that ultrasound picks. So you have cardiac abnormalities. So VST, AVST, stop, coarctation. So these are the defects, the cardiac defects that are associated with increased NT. Then you have the other structural abnormalities like CDH, omphalocele, dysplasias, renal anomalies, and the body stalk anomaly. Now, the baby will be grossly deformed in all these things, so that will be picked easily. Okay, now we have genetic syndromes also, like Noonan syndrome. So after Turner, Noonan comes, if you remember the list. And then lymphatic abnormalities, which primarily manifest in the forms of cystic hygroma. Okay. Now, beautiful 3D. This is a 8-9 weeker baby. Great. We just have started seeing the limbs. And now the shape of the head is lost. So ossification of the cranial bones, the calvarian bones, they occur at 10 weeks of gestation. So after 10 weeks, if you are not able to see the vault, then it's pathological. So abnormal irregular head shape, they will guide you to the diagnosis of the Acrania-exencephaly and anencephaly sequence. So first there is absence of the bones, then the brain parenchyma herniates. Just like in this picture, you're seeing that the shape is not maintained and it is in direct communication with the fluid. Now, if you do a follow-up, the amniotic fluid becomes echogenic. So that is exencephaly, and eventually it gets dissolved. So everything above orbit is gone. That is anencephaly, and amniotic fluid appears more echogenic. Now the abnormality. Early pregnancy scan. You were doing NT&B, started focusing on the head. I don't see a structure in mid. No, early pregnancy. I'm not looking for corpus callosum at this point of time. Do you remember we see nice butterfly-like structures? Very good. So common cavity. I'm not able to see the interhemispheric fox. Not seen. Here also I'm not seeing the fox. So fox is gone and you have fused thalami and a single ventricle, monoventricle. Diagnosis? This is you're picking as early as 12 weeks, 13 weeks. So holoprosencephaly. Association associated with syndrome strikes you now. You want to look for all the signs of that syndrome. Trisomy 13. Okay, so FARCs also. Calvarial ossification and FARCs, 8 to 10 weeks. If these two structures are not seen, this is pathological. Now, once you diagnose lobar holoprosencephaly and you get other findings of trisomy 13, it's going to alter the screening and diagnostic options, and hence the management of the entire pregnancy and future pregnancies will change. So association with trisomy 13 needs to be established. Now diagnosis. This 2D image we have done. You have taken the tomographic sections from the 3D. These are the slices. And at multiple level of slices, first we are seeing some fluid, then some soft tissue herniating. This is choroid plexus. Okay. Choroid plexus. Going below. This is the occipital bone. Okay. Posterior aspect we are not able to see. Something is herniating outside through that defect encephalocele. With the help of 3D, you can see what and all structures are herniating at different levels. Single image will give you everything. Now identify the abnormality. Chocolate question. Again, NT&B scan. Okay. This is a section slightly posterior. I've taken the section towards the back of the baby. So limbs, head, everything is fine. I'm trying to focus at spine. Do you find any abnormality? So we are trying to focus through the spine. And this is how you look at the spine once you're doing a scan of 12, 13 weeker in coronal plane. So this is a normal scan, coronal plane, normal appearance. 3 echogenic lines separated by 2 anechoic or hypoechoic areas, coronal section, 3 ossification centers. Now, a 3D image and post-mortem specimen. This is myelomeningocele, NTDs. This is how NTD looks like. So these are the limbards. This is hardly 11 weeker, and we can pick it very easily in the 11 weeks. These abnormalities. Okay. So the coronal section of the spine, once you are taking, when you are screening or cruising through the spine, the image happens to be like this. 3 echogenic lines, 3 ossification centers, and 2 hypoechoic lines in between. That's how normal spine in coronal plane would look like. Okay. Easy one again. And you have to tell me which syndrome is associated. Very good. Syndrome 1, 2, and the third line. Okay, good. Post-axial polydactyly, extra digit here. This is 10 weeker. Association. So again, syndromic first, Meckel-Gruber, Joubert, and then Patau, trisomy 13. Classical case, not very common, but classical. You don't see the digits, second, third digits, they are gone. And the hand is like the picture. 3D is also available, 2D is also available. Can happen due to anything, something is wrong with the limb. So second and third digit does not form. What is this called as? This limb. What is this limb called? Okay. Have you seen such case where the middle digits are not formed? This is ectrodactyly. Split hand. Most common syndrome associated is ectrodactyly, ectodermal dysplasia, and cleft lip and palate. Okay. 10, 11 weeker. 2D is available to you, and this is the 3-dimensional image. Now the diagnosis. Very good. Some subcutaneous edema is there. Okay. I can see limb birds nicely. Here also we are seeing the limb birds. Yeah. Do you see the lower limb buds, lower limb buds? Just so we are seeing the upper limb buds. No, we don't see the lower limb buds. So diagnosis, it looks like a mermaid to me. No lower limbs. Sea-like. Okay. So diagnosis is she might have taken. Are we at the right pace? Should we go a little slow? Size, we see. We are not seeing the bud only. The lower limb bud is not there. Upper limb buds are present, but the lower limb is not there. It happens that both lower limb buds might have fused, and that's why they are not seen as distinct entities. Sirenomalia. So the fused lower limb buds that is associated with renal agenesis, imperforate anus, genitalia is absent, and a single umbilical artery. So at 9 weeks, the picture looks like this. So when you're doing a 9-weeker scan, say she has come for localization only. If you're seeing 4 birds, you're happy. But if only 2 birds and the abnormal shape like this, then you should think of this entity also. Okay. Early pregnancy scan. This was the first scan. Followed up the second scan. Empty G-sac. Irregular G-sac. A big amnion. And something has gone wrong with the trophoblasts here. The trophoblastic reaction is also not very homogeneous. It has become somewhat hypoechoic. Yes? So these findings in the first instance, they are not diagnostic, but they are suspicious. If I have an irregular sac and a large amnion, so they are suspicious. But 11 days later, I still don't see any sign of life. Along with some hydropic changes here, they become hypoechoic in the trophoblast. It's a non-viable intrauterine pregnancy. So these are the hydropic changes.